So if you don't know what the metaverse is, it is the augmented reality which Mark Zuckerberg talks about. Okay, so this is we're going on to the talk. This is Dr. Prasanna. So he has done a lot of work on MIGS as well as a lot of works on teaching and augmented reality and virtual reality. So here we see this on the left here is the old original iStent, and on the right, top right here is the newer iStent, and on the bottom right is the iStent W. That is the one which has that is the iStent W, which has a wider bottom. So we will see why the wider bottom is also there. Okay, so this is Dr. Prasanna Venkatesh details. So he has been to WGC 2019, 2023 and researched on MIGS, and the first few slides are the intro slides which we have already seen. We will go to the first iStent, that is the first generation iStent, which looks like a snorkel, and here in this series it has a lumen and a snorkel, and it is a self-defining tip which is engaged into the angle, so into the nasal angle, and this is the injector which is used. Okay, so usually you look for an open angle patient with two anti-glaucoma medications, and this is a typical patient which you will use. And once you make sure of all the findings, okay, so he's doing a cataract surgery with a B-hex pupil expander. So that's a small pupil. So he has put the B-hex pupil expander, and he has gone and just going through the cataract surgery. At the end of surgery, at the end of surgery, you put in the surgical gonio lens. I'm sorry, I'm clicking the button and it's going to the next slide. Yeah. So at the end of the surgery, you position the patient, you put the cohesive viscoelastic, and this is a video where he lost the stent. So if you lose the stent, you can actually with great difficulty you can actually put it back into the injector, because the stent has to be put in with the injector. You cannot just grab it with any other instrument and inject it. So that is one thing. Don't lose the stent. If you lose the stent, it is quite difficult, but you can put it back into the injector and use it. So you can visualize the stent by using gonioscopy. With gonioscopy you can see the stent in the angle, and you can also use an OCT. So this is an anterior image where you can see the back shadowing at the place where the stent is placed. So this will show you that the stent is perfectly placed. The second generation is what is available right now. So this is a different shape. You have the central outlet at the bottom here, and three other outlets here, and at the back there is a central inlet. So this is what is facing the anterior chamber. This goes at the trabecular meshwork. This goes into the canal of Schlemm. Okay, and he has shown in a study that 84% of the eyes in the iStent phaco group were medication free at 23 months. So that is what his study was. But it is always advisable to put maybe two iStents in the same eye, because with one iStent the reduction may not be that adequate. And this is an OCT again showing both the stents in place. And this is another prospective study which Prasanna had done of 26 glaucoma patients, and he showed that there is good reduction of IOP, but there is a post-op day 1 spike which will come into effect later, and with number of AGMs, 0 medications, 91% of them were medication free, whereas 46% had one medication, 36 had two medications, and few more had more medications. And always there is a baseline and there is a spike which happens before the drop happens. So you have to be aware of the spike, immediate post-operative spike. I'm going to skip these slides about the study, and this is the difference between the iStent and the iStent W. The W has a wider flange here to prevent it from going into the Schlemm's canal completely. The flange prevents it from going more than the recommended amount. And this is a video showing that. If you see, this is the trabecular meshwork, and this is the injector. Once you put it, it goes here. If it pushes a little more, it can go into the Schlemm's canal completely. So then the next version has a wider flange, and after the injector is placed there, the wider flange prevents it from going into the trabecular meshwork too much. Okay. And he had an unusual post-op where patient after MIGS developed Uret-Zavalia syndrome, which usually happens after a very high IOP spike. So it is also possible to have such a complication. And that patient also developed an arcuate RNFL defect. So this is that patient who had an iStent, but after the surgery, he developed Uret-Zavalia syndrome. I think he put only one iStent there. So if you're putting it, you might be recommended to put at least two. And some glaucoma surgeries can result in Uret-Zavalia syndrome. That was his case report. So in Indian perspective, there is less data from Indian studies and the replicability of outcomes in India compared to Japan and other places where MIGS, and US and where the other places where MIGS is more common is being studied. So we have to be aware of that. And most glaucoma practitioners here, we get advanced cases, whereas the mild and moderate cases may be on medications for a long time. So this is more suitable for mild and moderate cases. And of course, the direct gonioscopy has a learning curve, especially surgical direct gonioscopy. And the procedure itself has a learning curve, and the cost for iStent is quite on the higher side. 42,000 to 95,000 based on the model. And this is a slide where he shows the normal angle followed by the angle after a Cahook dual blade goniotomy, and I think this is a bang, and also I think the other ones where the iStent was implanted, you get a back shadowing at the angle. Okay, so you see the angles actually open up if you have a good enough anti-segment OCT. So this one, he actually calls it the bird beak appearance. Okay, so there's a bird beak appearance, whereas in I think that's a bang, you have some leaflets remaining after surgery, whereas if it's a KDB, you have a wide open angle without any leaflets there. And one of the other MIGS, technically MIGS, is the endocyclophotocoagulation, where you use an ECP machine and you go in with the endoscope, which goes into endoocular endoscope, with which you can see the ciliary body, and you can laser the ciliary body. You can cyclophotocoagulate the ciliary body and reduce the aqueous production. So you are tackling not only the outflow, you are tackling the production also directly. And he also suggests there might be a time when we can use compound MIGS, where you actually do cyclophotocoagulation as well as target the outflow with a regular MIGS. So you don't have to go to a trabeculectomy even after that. So this is his opinion on combining trabeculectomy with this one. So this is the compound MIGS surgery which Dr. Prasanna had attempted. He had put ECP, and also he had done a KDB Cahook dual blade for the trabecular meshwork. So that would give a much better combined IOP reduction, maybe probably even as good or better than trabeculectomy, since we are tackling the aqueous production as well. Then now we go on to the 4D Metaverse, which all of you have been waiting for. The Metaverse is here already. There is a virtual reality headset. I'll just talk to you about what it is while the Metaverse is being demonstrated. So there is nothing here on the metaverse, but I'll just tell you what it is. It's a virtual reality headset in which you have the Microsoft HoloLens, and once you wear it, you can see the virtual images in front of you in free space. And using your hands as controllers, you can grab these models. So it's an eye model of the eye in front of you. You can grab a iStent or a Kahoot dual blade, and you can practice the surgery in front of you. So that is what the metaverse is created for. So the most advanced version of this is the headset which you put on. That's a Microsoft HoloLens, so it is quite on the more expensive side. But you can also do a basic version of this using a smartphone with augmented reality. So you have a smartphone with the camera on. You use the Metaverse app. I think it's called MCI app. Yeah, so it's the app which is there from MCI, Mahatma Center for Moving Images. And once you put that app in your phone, through the camera you can see the virtual models in front of you. You can move the camera and go all around it. You can go zoom into the angle, and you can move around, look at the fundus also, because he has placed fundus images also in that virtual eye. So I think for the next 5 minutes, those who want to try out the metaverse can do so. And this is a list of publications from Dr. Prasanna. Thank you.